You're tuned into Out of the Voice Box, where candid conversations bring great minds together from across the nation.
Join us for access to cutting-edge voice-related information you won't find in a textbook. Yet.
We are your hosts, Sara Charney
and Nathaniel Sundholm.
The opinions and viewpoints on this program are those of the featured individuals, not their respective institutions. This program is not a substitution for medical care. On today's episode, we'll be discussing the evaluation and management of unilateral vocal fold paralysis. We are joined today by Dr. Will Karle, a fellowship-trained laryngologist at Mayo Clinic-AZ, who's here to help answer all of our questions. Thanks for joining the conversation, Dr. Karle.
Well, thank you to both of you for having me today. It's a pleasure.
We know this is the end of a long clinical day, and we appreciate you taking the time to chat with us.
Of course, it's always fun doing East Coast, West Coast meetings. So,
Absolutely. All right. So in order to provide some background for our listeners, let's set the stage. So what would you say are the top 3 most common causes for unilateral vocal fold paralysis that you see clinically?
Well, the same thing for me is for most people. Number 1 is going to be cancer. Number 2 is typically some consequence of surgery, typically thyroid surgery, but it could be anything in the chest or the neck. And then lastly, idiopathic. So for my practice and for others around the country and for the literature, those are definitely the top 3 by far.
And for our folks who may not be aware of some of this terminology, can you briefly explain what an idiopathic unilateral vocal fold paralysis even means?
Absolutely. So idiopathic is a word that doctors came up with to make us sound smart, but in reality, what it means is that we don't know. So it's an unknown cause for one side to be not working. It means that we've shown that there's no cancer that's causing it. There's no evidence of anything else causing it. There wasn't surgery that could have caused an intubation. So we're left twiddling our thumbs, not knowing. So to sound somewhat smart, we say it's idiopathic.
So if I'm hearing you right, if someone was to go into a voice center having some complaints of breathiness, a quiet voice, we take a look at their larynx using an endoscopy exam and something's not moving. In order to determine that it's idiopathic, there are a couple of things that you might order or do to rule out the insidious underlying thing.
Absolutely. And that partially depends on the patient's clinical history. But as a general rule of thumb, what pretty much everyone will do across the country is order a CT scan of the neck, which will basically encapsulate the entire course of the recurrent laryngeal nerve, the nerve that moves your vocal cords, to make sure there's no masses or lesions along that entire course that could be causing this issue. Assuming that that doesn't show anything, depending on the patient's clinical history, you might order something here or something there, such as a thyroid ultrasound. Some practitioners like to order certain blood work to test for certain diseases, such as syphilis or other zebras, uncommon causes of a vocal cord paralysis. But for the most part, the most common thing people will do is just that CT scan of the neck. And if nothing else really stands out, that will be your diagnosis of idiopathic.
Speaking of various reasons for a nerve maybe to have an impact on vocal fold movement, rumor has it you have some inside knowledge on the finities of ACDFs. For our listeners, an ACDF stands for an anterior cervical discectomy, which means decompression, and fusion. So essentially, anterior means that the surgical incision is being made in the front of the neck. And then this type of surgery is most often used to decompress the cervical spine and then reinforce the cervical spine against degenerative changes. So back to you, Dr. Karle. We know, for example, there are some differences depending on if neurosurgery is completing the operation or if maybe orthopedic surgery is completing the surgery. Can you explain what some of these differences are?
Absolutely. So I wouldn't exactly call it insider information, but in my experience, there's typically 2 different fields that will do this type of surgery. It's either the neurosurgeons or the orthopedic surgeons. Typically, a neurosurgeon will go in on the right side of your neck to get down to that location to do the surgery. On the other hand, an orthopedic surgeon almost always will go on the left side. Now, there are nuances to both of these depending on exactly what they're doing, but this is a general rule of thumb. If an ENT is involved for getting the approach, so getting down in the neck to the spine, which we're sometimes asked to do, will almost always go on the left side. There is a difference in the course of the recurrent laryngeal nerve on both sides, and for several different reasons, it's safer and easier, at least in an ENT's opinion, to go down the left side. So if I was the one doing an ACDF surgery, which I would not because I'm just a laryngologist, just an ENT, I'd only be doing the approach, but if it was my decision, it'd only be on the left side. The con for going on the right side is that you're at a higher risk of damaging that nerve. The pro for the operator, though, is that it is more ergonomic if you're right-handed. So my belief, this is not a textbook, my belief is that an orthopedic surgeon could basically put a screw in or a plate in while they're standing on their head, so they don't care much about ergonomics. So they'll do whatever is the safest thing for the patient, whereas neurosurgery typically has been taught to do more things ergonomically. So classically, they've been taught to go more on the right. So that's typically why you'll find one doing one and one doing the other. That being said, a great neurosurgeon is still better than a bad orthopod and vice versa. So I wouldn't say you should pick your surgeon based off of that alone, but it is something that I personally would take into consideration when choosing this type of surgery for a family member or a friend of mine.
So it sounds like to me, if you were a patient looking towards one of these surgeries, you might want to know who is doing your surgery. You might want to ask how they're going to approach it. And if you have any concern about your voice or any concern about breathing, it might be good to get a look at your vocal folds before you even have a surgery to make sure things are functioning the way that they should be. Do you have any thoughts on that? A pre-operative laryngeal exam.
Yeah. So when it comes to asking those questions, those are totally appropriate questions. I'd say it's inappropriate to say, no, I want you to go on the left side. You should do what the surgeon feels most comfortable doing. You don't want to get them out of their comfort zone. That being said, in terms of the preoperative evaluation, most orthopods and neurosurgeons won't request that from an ENT or someone else to look down at the vocal cords unless a patient has a preoperative vocal complaint. However, if there is a preoperative vocal complaint, it's very common for them to ask us to take a look to confirm that both vocal cords are moving just fine. The reason why we want to confirm that is because after their surgery, if we took a look then, one of them might not be working, and we want to have a good preoperative exam documenting that.
When it comes to the typical management for unilateral vocal fold paralysis, we know that there are a couple things that we can do. 1, do nothing. 2, voice therapy. There's temporary solutions in terms of injectables, which we will be asking you about, Dr. Karle. There's permanent solutions, and then there's some other considerations that we know. But can you tell us a little bit more about the pros and cons for these options and other considerations and when you would kind of think about each of these options?
Absolutely. So the most important thing to keep in mind first is the timeline of when the vocal cords stopped moving. So typically you won't want to consider doing a permanent solution until after there's been a year from the time of original vocal cord paralysis. That being said, if you know the cause of the vocal cord paralysis and you know that the vocal cord won't come back, for example, if someone did a surgery, they cut the nerve in 2 pieces, they did not stitch it back together, they didn't put anything to put it back together, we know it's going to be that way. You can do it as early as 6 months afterwards. The reason why you have to wait that long is because you want to wait for the muscle to atrophy down to the size it's going to be at for a long time. So that brings us to what do you do before a permanent solution, and that's those temporary solutions, those injection laryngoplasty options that you mentioned. Now, the other alternatives that you also talked about was do nothing or voice therapy. Basically, you can do voice therapy if someone has a mild complaint of their voice after a vocal cord paralysis, or if someone that really does not want to tackle a temporary or permanent solution. But typically, if someone has a vocal complaint afterwards, we'll offer them some type of temporary solution until that timeline is up to allow us to do something more permanent.
Would you also say that in terms of having voice therapy as an option, it also kind of depends on where that vocal fold is paralyzed?
For the most part, I would say that voice therapy can be used as an option for pretty much any of these patients. I can't imagine a scenario where you wouldn't get some benefit. The question is, are you really getting the most bang for your buck? So if someone's really far lateralized and they have an extremely breathy voice, how much benefit you'll get out of voice therapy is questionable. But if you're making some contact, you'll get some improvement. The question is how much. I like to think of it this way. If you really want to get the best voice possible in that first time period before we do something permanent, in my opinion, your best bet is to do the temporary injection and also voice therapy.
So just to clarify for our audience, we know that vocal folds have to open and close in order for us to get a voice that works and is loud enough to be heard. When a vocal fold stops moving, sometimes the vocal fold can be frozen in an open position, which makes it difficult to get any level of volume out. And so now that we've clarified this a little bit, Dr. Karle, can you explain the nature of what intervention means? Is it actually to get the vocal cord moving again, or is it more of a vocal fold placement procedure?
Good question. So when it comes to the temporary solutions, all of them are doing the exact same thing. They are just taking that vocal cord and hopefully moving it to the middle. That is their only intent. They won't help with the breathing. They may help with swallowing a little bit, but the main goal of doing these injections is to get better contact, to get yourself a better voice. What a lot of questions come into play for this is what exactly should you use, but the goal for all of them is to move that vocal cord to the middle.
In terms of injectables, can you kind of tell us about your go-to injectable, why it is? Are there other options? And can you kind of tell us about the different options and what the differences are?
Absolutely. So there are several different options out there. Typically, your physician will choose an option based off of what their institution already provides them. Most institutions won't provide all of these things, and there's typically one that they'll lean more towards. So at my old institution, we used Symetra, which I loved. However, that substance is no longer produced, so I had to switch. And at my new institution, we use Restylane here. That being said, I personally am probably going to start playing a little bit with switching my practice over to Juvederm. Typically, the Symetra and the Restylane are usually quoted as lasting around 3 months. Juvederm is a thicker material, very similar to Restylane in the sense that it's made from hyaluronic acid. That one will last a bit longer than the Restylane, though. How much longer is questionable, but it can last up to a year. You're also left with the option of Prolarin gel, which is very short term, lasting usually about a month. Prolarin Plus, also called Kaha, can last up to a year and a half to 2 years. And then the most recent product to come out on the market for this indication is something called Silk Voice. How long that one will last is still to be determined, but currently literature is showing that it will last at least a year.
So for permanent solutions, which are the most common materials used and which one do you like to use? Can you tell us a little bit more about the pros and cons for that?
Absolutely. So when it comes to permanent solutions, there's two main options. The first is to inject fat. That's typically autologous fat, so fat from the same patient, typically harvested from their abdomen, then injected into that vocal cord. One of the main downsides of that procedure is that an unpredictable amount of that fat will be reabsorbed. So you have to over-inject that vocal cord and then wait to see how much is reabsorbed, meaning that it's not infrequent that you'll have more than one of these procedures to get you the result that you want. The other type of procedure that can be offered for a permanent solution is something called a medialization thyroplasty. There are several different products out on the market that can be done for this type of procedure. The one that I use is Silastic, whereas my partner, Dr. Lott, typically prefers to use Gore-Tex.
So can you talk to us a little bit more about those two, especially Silastic, because that's what you use, and talk to us about the carving and how did you practice doing that? We want to know it all.
Absolutely. So first I'll start off with the Gore-Tex. So that is not my go-to, but the Gore-Tex is typically a piece of fancy fabric, cardiac fabric, that's folded on top of itself, pushed in underneath a carved out window of your thyroid cartilage, the protector of your vocal cords, to basically push over that vocal cord. Again, this is very similar to what we were doing with the temporary solutions. We're moving the vocal cord more to the middle. Now, what I use is a Silastic, which is a very fancy piece of plastic. I use to describe that to my patients as. Very similar to the Gore-Tex in the sense that you're using it to push over your vocal cord. That being said, the difference between this and the Gore-Tex is that at first you're measuring exactly where you want that push and what size you want the push to be. Once you've measured that, you then take your carving block out with a fancy carver, carve out the exact wedge that you want, and then pop it into position to push your vocal cord over in the exact spot that you want it to be. On the other side of things, Gore-Tex, you put a little bit in, test the voice, don't like it, put a little bit more in, maybe push in one direction, push in a different direction. So in both, you are fine-tuning what the push should be. One is just you're carving outside the patient, the other is just putting more in. Now, the question is, how do you test someone's voice during this? Well, this is a unique procedure in the sense that a patient is only half awake, half asleep, meaning that when we're testing their voice, they're awake for that part. So they'll be saying 1, 2, 3 or other phrases so we can see exactly where we push that vocal cord over to get the best voice possible for them.
All right, I'm very excited about this conversation. I have a couple of follow-up questions. For the Silastic, it comes delivered in a brick. And from my understanding, so you made this all sound very simple, right? You go in, you make a window, you do a measurement, you cut it, you get it perfect, you put it in the right spot. But just for our listeners, can you describe what you even do to measure? And then is this something that you are doing in the operative room, that you are carving this brick to make the perfect fit for someone's window within you are putting this implant?
All good questions. So yes, to get into more detail, once you've carved that window into the cartilage, you now have access to the underside of the vocal cord that's paralyzed. Once you have that, you'll use these particularly manufactured metal rods that have little markings on them with millimeter hashtags that show you exactly how long each one is. You then take those individual sticks, put one at a time, and press into the patient's vocal cord. Again, you're underneath it, and you'll measure how far in, and you'll see by looking at the window where you're pushing that in. And at that point, you'll test their voice.
Okay, so you're testing the voice as you're using these, we'll use the word spacers just for the purpose of conversation. So as you're using these spacers to try and get the best guesstimate of how wide you would want this implant, and you're like getting the patient to talk.
Exactly. And you want to know the two most important things, which is the maximal amount of push. You want to push that vocal cord in, and exactly where you want that push to be located. Typically, that push will be mostly in the back part of the vocal cord.
Perfect. And so kind of along those lines, how do you avoid that kind of what we've been talking about, that brick wall phenomenon? It's kind of a stiff material. So when thinking about placement, mucosal wave and vibration of the vocal fold is also very important, as we know, for voice. So how do you kind of deal with that?
So a lot of us will use a camera in the nose down into the throat to visualize where the vocal cord is. However, just the appearance alone isn't that helpful. It will tell us if we're midline, but like you mentioned, you can get that brick wall phenomenon by getting yourself over to the midline but putting too much material underneath it. So you can have a perfectly looking vocal cord on a picture because it looks right in the middle, but then when you hear them talk, there's no vibration. You're not hearing a good voice whatsoever. So there's really no way of seeing that when they're just breathing. And even on your normal camera, it's hard to really visualize that since you're not using a stroboscopy. Really what will tell you that is the sound of their voice as you're pushing over. So if it looks like it's midline, but they don't sound great, it's typically because you're getting that brick wall. The only thing you can do is just change where that push is and how deep that push is to still get you midline, but to not get you that brick wall phenomenon.
So you've mentioned this concept of voice tuning in the operative room. Essentially, the person is in a semi-conscious state, also known as twilight, and you have the patient talk, say some words, count, hold out an E. Is there anything that we as speech language pathologists can do better to help prepare these patients for this intraoperative voice tuning? Are there phrases that might be helpful or automatic speech that we can prepare the patient to think about saying in this semi-awake state?
So I wouldn't say there's necessarily any phrases that would be helpful for them to get primed with. However, I have all of these patients meet with either Sara or one of our other speech language pathologists prior to the surgery in an attempt to unload their voice as much as possible. Very commonly, these patients will have a very tight voice to try and compensate for their paralyzed vocal cord, and it makes it more difficult to fine-tune that voice in the operating room if they still have that tight phonation. So a way to combat that is actually commonly to make their voice sound a little bit worse preoperatively by having them work with a speech language pathologist to really unload that supraglottic squeeze to try to just use their vocal cords for phonation. In terms of what phrases they should use intraoperatively, at that point it's just the laryngologist who's there, so it's up to them to try and get them further to unload their voice.
So do you ever like try out people's comedy routine or, yeah, tell me a knock-knock joke? No.
Occasionally. Okay, I'll say very infrequently though. But maybe I should. If you've heard good stories, I can maybe incorporate that into my practice.
I love it.
That sounds like a coffee table book if I ever heard of one. Knock-knock jokes heard in the operating room.
We can be the first publishers. I love it.
Absolutely.
So it's guaranteed that might not go as planned the first time around. There's some patients that will require a revision, and maybe it's not necessarily a failure. Maybe there's some other causes for someone needing revision. Can you kind of tell us about some of those?
So I personally, I would call that a failure. I call it the way I see it. And if someone didn't end up with a good voice afterwards and they require a revision, it's a failure. It happens. I usually quote patients as having about a 5% chance of needing a revision, but that rate could be a little bit higher, a little bit lower. That's typically what my experience has been and also what the literature says as well. And it's hard to predict who necessarily will be a revision and who won't be. I've had plenty of patients that had a great voice in the OR, and I thought, wow, that was pretty easy. And then a month later, their voice isn't great. I'll have them wait a little bit longer, work with speech pathology, and their voice still isn't great, and we're not getting good vibration, and we have to go back. And that's something I couldn't predict at that time. I'll have other patients where I say to myself, that did not go fantastic. We did not get a great voice out of them in the operating room, and I'll see them back a month later, and they'll have an absolutely perfect voice. In the end, though, it's a failure, but it's predictable that some people will have it. Patients should be aware that their physician did everything in their power to try and get them the best voice possible, and that they just happen to be part of that bad luck 5% that needs to go back. Typically, physicians won't want to rush back unless it's very obvious that the position of the implant is in the wrong place. They'll typically want to wait a little bit of time to make sure all that edema has gone down. They've had a chance to work with speech pathology for a couple sessions to really make sure it's not something functional that's going on here.
If someone has a surgery coming up that they need to be intubated for, is that something that is part of the conversation preoperatively? Like if you can time it afterward or anything like that, is that something you consider?
Oh, absolutely. I always ask these patients if they have any planned surgeries coming up. The surgery that we're offering is not a life or death cancer surgery. This is to improve their voice. So if there is another surgery that they have to have done, typically we'll go with that one first, have them heal up, and then proceed with our implant. Otherwise, we typically ask that they wait for 2 months after the surgery to get intubation. Apart from that, we also ask that they talk to their anesthesiologist about using a smaller size ET tube if possible.
When you do a revision, do you typically just do the same thing over again? So if you use Symetra, do you use Symetra again, or would you ever consider switching to a different implantable? Would you consider going from Gore-Tex to autologous fat? Is there a difference in what you do the second time?
Good question. So I would say when it comes to injectables, I wouldn't necessarily switch which one I use. If it didn't go well, I'm not going to blame the injectable. I'm going to blame myself. I'm going to say that I didn't get it into the right spot. The properties of the injectable did not really hurt us with that. That being said, if we want to change the duration of the action of the injectable, then we can consider using something different. But in terms of we didn't get a good voice the first time, I would review the tape to see where exactly things went. And if they went in the appropriate spot, then it's just possible that our second injection is not going to get us a great result either. But I typically will use the same injection. When it comes to a revision surgery for emulization thyroplasty, I'll typically stay with the silastic. One thing different is I will put on their possible arytenoid abduction. So possible changing the position of the arytenoid if we can't get a great voice out of someone in the operating room with a silastic implant. That being said, typically the reason why they need a revision is the implant was just not carved to the right size. Whether it was too anterior, too low, too posterior, whatever it is, typically we can find that good voice in the operating room without having to do something with the arytenoid.
Do you feel like it's more common for an implant or injectable to be too anterior or too posterior when you're having difficulty getting a good voice?
I would say that it's extremely variable on the practitioner. So in general population, not referring to laryngologists, but to general ENTs, the more common mistakes you'll run into with a permanent implant for mutilization thyroplasty is that the implant is either too high or too in front. So either too superior or too anterior. I wouldn't say that it's a common problem with laryngologists. When it comes to problems with the injectables, one of the issues with them is that they won't stay exactly where you place them. So it's not uncommon for them to track anteriorly when you didn't want them to. That being said, because they are so mobile, oftentimes if they have a very pressed voice day one, that voice can often go into a very good voice 7 days after your injection. I'll just warn them that it might take a little bit longer that time.
For postoperative voice care, do you recommend any level of voice rest? Does that recommendation change whether or not the person had an involvement in their arytenoid, if they had like an arytenoid adduction or arytenoid pexy? What's it called, Dr. Karle? You know what I'm
Yep.
saying. You can correct me in your answer. So talk to me a little bit about your post-operative counseling. When can the person expect to have a good voice after having a medialization procedure?
So there's some controversy about voice rest after these procedures. I would say that in general, though, most people that do silastic will have them start speaking the same day. If the patient wants to, there's no reason to do voice rest. If they use Gore-Tex, I'd say it's more common to do at least a couple days of voice rest, up to a week, with the idea that the Gore-Tex isn't as stuck in place as the silastic. When I'm counseling patients about what to expect, I say that you might have a perfect voice day one, and then day 7, it gets terrible, and then day 14, it's fantastic. It might be great from day 1 and stay that way. It might be terrible from day 1 to day 30, and then day 31, it's perfect. I tell them not to expect a specific thing, that I want to see what their voice sounds like a month afterwards, but that point before the month, it can be all over the place and not to be concerned about it in that time period.
And then just little extra questions that we have. One, is there a side, your left or your right vocal fold, that's more likely to be paralyzed? And how common is bilateral or both sides for them to be paralyzed at the same time?
So the left side is much more common than the right side in terms of paralysis. The thought behind why that is again, there is a difference in the course that those nerves take as they go down from your brainstem down into your chest up to your throat. It is a longer course and more tortuous course on the left side. So the thought is that there is more room for things to get into it, more chances for cancer to pull it, and it's more fragile because it takes a longer course. That being said, I probably do 4 left sides for every 1 right side that I do in the operating room. When it comes to bilateral vocal cord paralysis, that is something that we don't love to see, because now we're not talking about getting your voice better, we're talking about your breathing. That's the much more important issue. Typically, that will lead to either a fancy procedure going through the mouth, or will lead to a trach for the patient, whether it's permanent or temporary. How common? I would say it's much, much less common than a unilateral vocal cord paresis. It's also very uncommon if we're talking about idiopathic causes of bilateral vocal cord paralysis. Typically, it's going to be a trauma or a surgery that's causing that specific issue. And a fun fact is that the way our recurrent laryngeal nerve, that important nerve that controls our vocal cords, for us, it goes from our brainstem, the bottom of our skull, down to the top of our chest and back up to upper part of our neck, which sounds like a kind of dumb way for our body to be designed. Much worse for a giraffe, for a horse. And a giraffe, same thing, goes from its skull base all the way down its neck into its chest, and then all the way back up to the top part of its neck to get into its vocal cords. So not the best design of us creatures when it comes to this nerve.
Wow, that's a very fun fact. I did not know that.
What's your perspective on the speech pathologist role in patients that have maybe a moderate or severe paralysis where they really don't have a great voice, and you hear them, you don't expect them to get better with therapy alone? Do you see there being a role for the speech pathologist, even though maybe therapeutic potential seems guarded?
I do, and typically what I'll tell patients is that it's up to them. So I would recommend for those specific patients that don't have a great voice, that have one vocal cord that's not moving, that if we're still in that time window where we can't offer something permanent, we should go with an injectable to give you more bulk and for the speech pathologist to have something to work with. At that point, it's totally up to the patient's discretion if they'd like to fine tune their voice and get even more improvement by working with a speech pathologist, or if they're happy with where they're at. Lots of times I'll have these old grumpy men that say, no, just give me the shot. I want to be done with it. We'll go from there. And then I'll have other people, working professionals, that really want to get the best voice possible and are really interested in working with speech pathology afterwards.
Sara, I have a question for you. So if you have someone who is severely dysphonic, maybe even profoundly dysphonic, and you see them for a preoperative evaluation, are there things that you are very sure to talk about during that time period to either help them get through this stretch where they are having a hard time communicating, and then counseling them for what to expect afterwards?
Absolutely. I think there's always something to talk about in terms of coordination of the voice and education on how the voice even works and what the rehabilitation process is typically like. If someone has no volume and they cannot project their voice at all, I do counsel them on personal amplification devices and things like that so that they can at least get through their workday and be able to complete their activities of daily living. So I do think that there's definitely a lot of education that can take place even before an event intervention happens.
I agree. One other thing that we talk about relatively often at the Emory Voice Center here in Atlanta is the concept of emergencies. You know, we really don't want to think about someone needing to yell for help or shout for help, but when you need your voice, you don't want to have to think about it, right? And unfortunately for this population, they are at risk for not being able to call for help from a loved one if they fall in the shower or if they're in a parking lot and they need assistance. So typically we have them get a noisemaker, like a whistle or a horn. There's a really awesome keychain now that has like a 120 dB alarm that you can trigger. Is very loud, very loud. For people with poor dexterity, I wouldn't recommend because it's hard to turn off. But yeah, I think it's important that while therapeutic potential to achieve full resolution may be guarded, there's a lot to offer in this interim, whether that be personal amplification or emergency safety, counseling them to call their fire department and police department that's in their town to tell them that, hey, someone here has a voice problem. You may not hear me if I call in emergencies. This sounds like overdoing it, but I think in the chance of an emergency, it's better to think beforehand than to regret after.
Absolutely, I agree with that.
When either of you meet with someone preoperatively and you know that they'll be going for a mulestation thyroplasty, what typically do you work with them on in that appointment?
So, preoperatively, depending on how their voice sounds at that moment, if I can get them to be maximally efficient in their voice with what they have, to unload any muscle tension that they might be carrying prior to their operation, I absolutely focus on that because that muscle tension is not going to go away after the injection or the medialization thyroplasty. So I absolutely try to unload as much as possible so that when they do have that kind of boost from the operation, that they're as efficient as possible.
The other thing that we talk a lot about is effort. So the amount of effort that people are putting forth during this time period when their vocal folds are not moving the way we would expect them to, we don't want to match that same level of effort So usually the thing that's most definitive for this patient group is the intensity range task. So we have people say the sentence, "We were away a year ago." We have them say that 3 times, once in their typical speaking voice, once as loud as they possibly can, and once as soft as they possibly can. And typically, with patients that have a significant and medialization worthy glottic gap, the effort level increases significantly for that highest intensity task. But more often than not, the volume remains relatively consistent. Nothing but breathiness increases. And so that gives us a really good chance to talk about, okay, you just took 30 breaths during the rainbow passage. That is exhausting when we think that 3 breaths is typical. Using that information of effort, I usually train a confidential tone, which is going to feel completely alienating to someone who's been working so hard to get any level of voice out. And it's usually quite freeing for them to realize that they can try 90% less, get the same amount of output that they get when they are pushing 130% of what they can do. And then, Sara, to your point about personal amplification, we're very consistent about having people wear it, try it on, talk to a nurse, talk to one of our physicians, wear it in the exam room so they can get the feeling of how it sounds. And depending on when they're able to proceed with a surgery, if they have the finances to do so, or if they have family that they have to support them during time, whatever, having the permission to use reduced effort, to have a tool to help amplify, that's usually what we spend the majority of time on in preoperative counseling. And then, we'll throw in some SOVTs like lip trills or bubbles in a cup, but it varies on what the patient feels like they're good at. For those of you listeners who may not be in a location where you have a physician right down the hallway or in the same room as you, I would encourage you to talk to actually pick up the phone and call the physician that is referring patients to you and have a conversation about what they think you do, about what you actually do, and what you both can do to complement each other so that the patient is getting the optimal care that they can receive. And I can't say that enough, because my job would be so much less valuable if I didn't have the fantastic physician colleagues that I have. And I would like to think that their surgeries would be much less successful if I did not exist and do what I do.
We like to think that, right? Hopefully.
Yeah.
All right. Well, this has been a lovely chat, super informative. Dr. Karle is just a wealth of information. We're so lucky to have him. So thank you so much for joining us, Dr. Karle.
Well, thanks again for having me.
And to our listeners, we'll see you next time.